Everyone, good evening. So today our topic is lipoprotein metabolism. So first of all, you must know about the lipoprotein. Lipo means lipid, which is conjugated with the protein moiety, protein molecules. So then called as a lipoprotein. Just see in the figure here, the protein moiety is going to conjugated with the lipid moiety, lipid molecules. So this is called lipoprotein. So lipoprotein are molecular complexes that consist of lipids and protein. And this is the general structure of lipoproteins. You can see here the free cholesterol is there, and then peripheral lipoprotein is there, phospholipid is there, cholesterol esters is there, triglycerides, that is nothing but the neutral fat, and then and non-polar lipids is there. So where we can see the in figure, there is a conjugation in between the lipids and protein moiety. So basically that consists of neutral lipids core. Neutral lipid means nothing but the triglycerides as well as cholesterol esters, which is surrounded by a coat shell of phospholipids, lipoprotein, and cholesterol moiety. And the polar portion, that is nothing but the amphiphilic in nature of phospholipids and cholesterols, are exposed on the surface of lipoprotein so that the lipoprotein is soluble in aqueous solutions. That's what the lipoprotein is soluble in aqueous solution. Aqueous solution means ether, alcohol, benzene. Yeah? So all these are aqueous solutions. So they are not going to soluble in water. So if I'll talk about the classifications of lipoprotein, so based on in two different ways they are classified, broadly classified. If I'll talk about the ultracentrifugations and on the basis of electrophoresis, ultracentrifugations, ultra fine particles were going to centrifuge with the highest speed. That is nothing but the centrifugation technique for the separation of molecules. So through that technique, we are going to separate the molecules. So ultracentrifugation technique, they have extremely high centrifugal force to separate substances based on their density and size. So that is the technique, analytical technique. And if you'll talk about the speed range, so that is very high speed. Almost 60,000 to 1,50,000 RPM rotation per minute. That much speed. In mean, we can call you can say almost 1 lakh times per minute. 1 lakh in mean 1 lakh RPM. You can, and this is going to mainly, this ultracentrifugation is going to mainly separate the cellular organelles, protein moiety, and all these. So this is the analytical technique for the separation. So based on that technique, the molecules, the lipoprotein is going to separate. I already told you that the based on the density and size, the molecules get separated. So first, you can see here the chylomicron based on the density and size. So chylomicron, VLDL, very low density lipoprotein, ideal density, intermediate density lipoprotein, low density lipoprotein, high density lipoprotein. So the density of chylomicron is less than 0.95 gram per ml. 0.95 gram per ml. Whereas very low density lipoprotein, the range is in between. You must know the range of this density. Okay, you'll get the MCQs from this. So the range of VLDL is 0.95 to 1.006 gram per ml. Whereas intermediate density lipoprotein, you can see here 1.006 to 1.019 gram per ml. Whereas low density lipoprotein, you can see here 1.019 to 1.063 gram per ml. Whereas HDL, high density lipoprotein, that is 1.063 to 1.21 gram per ml. So based on the density and their size, these molecules can get separated. So that is based on the ultracentrifugation. Whereas based on the electrophoresis technique, you must know about the electrophoresis. So electrophoresis, chromatography, all these are analytical technique. Commonly used in our laboratory. So all these techniques. So where in electrophoresis, the name itself indicate in the presence of electricity, molecules can get separated. When we are going to apply the current, so based on that, molecules, analytes get separated in an electric field. So this is the technique. There are methods used to separate charged molecules like a protein, nucleic acids, and other molecules. So that is also based on size and charge nature. Here in ultracentrifugation, there is a applications of centrifugal force, where in electrophoresis in an electric field, the molecules get separated. Common, we are going to use gel electrophoresis. And here, if I'll talk about the principles, the basic principles of electrophoresis, so the migration of charged molecules in an electric field, whereas positive charge molecules, that is called as cation, that migrates towards the cathode, whereas negative charge molecules, anions, that migrate towards the anode. And the rate of migration will influence or depend on the charge, size, shape, and properties, even in medium, and which type of buffer you are going to use in that. So that is the factors. And then molecules can, when you will apply the current voltage, then molecules can get separated. So that is the basic principles of electrophoresis. So based on the electrophoresis techniques, on the basis of electrophoresis, molecules can get separated when, so this is the point of origin. And the molecules, when you apply the current in opposite directions, molecules get separated. So moves towards the opposite directions, opposite charge nature. Okay. So first you'll get here. So it's chylomicron is there. Then LDL. LDL is also called as a beta lipoprotein. Sometimes you will get a questions like a beta lipoprotein. So that means nothing but the LDL, low density lipoprotein. Whereas sometimes you'll get a pre-beta lipoprotein. That means very low density lipoprotein. VLDL, very low density lipoprotein. That is nothing but the pre-beta lipoprotein. Whereas HDL you can call it as a alpha lipoprotein. So just you remember HDL alpha lipoprotein, VLDL pre-beta lipoprotein, then LDL beta lipoprotein, like that you can remember. Okay, so there is no any confusion. So here this is the minus charge, whereas the anode, this is the cathode minus, whereas anode positive charge. So according to that charge nature and shape, molecules can get separated in an electric field. So based on this electrophoresis and ultracentrifugation techniques, the lipoprotein is classified like that. Coming to the lipoprotein. Apo, supportive. Proteins that bind lipids such as a fat, cholesterol to form lipoprotein. So here proteins that bind lipids such as fat and cholesterol to form lipoprotein. That transport the lipids through the lymphatic and circulatory system. And for that sake of that, a protein is play an important role to transport the lipid molecules. And same like here enzymes and isoenzymes, they are supportive to the enzyme. Same like here also, a protein is supportive to the lipoprotein. So these different types of lipoprotein and respective protein is there, and they are going to help for the transport of lipids. So chylomicron, there is a protein A1, a protein second, a protein fourth, and B48, C1, C2, C3, and a protein E, whereas VLDL, a protein B100, a protein C1, a protein C2, a protein C3, a protein E, whereas ideal, intermediate density lipoprotein. So a protein B100 and a protein E, whereas LDL, low density protein, a protein B100, a single one. Sometimes you'll get that questions MCQ, so you must know the a protein B100 is for LDL, whereas a protein B48 is for chylomicron, and here acetyl high density protein. So a protein 1, a protein second, a protein 4, a protein C1, C2, C3, a protein D, and a protein A. So apoprotein are the protein molecules that bind to the lipid, and that is fat and cholesterol, to form lipoprotein, and which will help to transport the lipid molecules, and they are important. So what is the major functions of that respective apoprotein? So apoprotein A1, activator of lecithin cholesterol transferase enzyme LCAT. We can call it as a LCAT. So activator of lecithin cholesterol transferase, apoprotein A1. So you can remember as a LCAT. Whereas apoprotein B100, VLDL secretion from liver. VLDL secretion going to secrete from the liver, whereas a protein B48, chylomicron secretion from intestine. So chylomicron secretion is going to from the intestine. For the sake of that, a protein B48 is responsible, and they are playing a vital role. Whereas a protein C second, activator of lipoprotein lipase. So a protein C second is going to activate the lipoprotein lipase enzyme, and then lipoprotein lipase will function there. Whereas a protein E, ligand for binding of several lipoprotein to LDL receptor related proteins. So all these are important apoprotein and their respective vital functions. So we'll go much detail about the individual protein. Okay. So first one is chylomicron. So chylomicron metabolism is also called as a exogenous pathway of lipoprotein metabolism. Exogenous means outside. Okay. Exogenous pathway of lipoprotein metabolism. So we are going to individual lipoprotein metabolism. Okay. If you get the questions like that exogenous pathway, that means nothing but the chylomicron metabolism. So this is the structure of chylomicron. You can see here the structure of chylomicron, where you can see the A protein B48, A protein C is third, A protein C second, and this is the phospholipid moiety and triglycerides and cholesterol esters, and then these are the cholesterol. Okay, so this is the structure of chylomicron. So just come to the source. So source of chylomicron is a small intestinal cells. And the diameter of chylomicron is, you can see here, 92,000 nanometer. You must know the diameter. Okay, you will get MCQs questions. So you can keep in chart of these different lipoprotein for the remember purpose. And density is less than 0.95, whereas protein content, sometimes you'll get how much protein content is there. So 1 to 2% protein, 1 to 2% protein, whereas lipids 98 to 99% lipid content is too much high in chylomicron, 98 to 99%, whereas major lipids you'll get that is nothing but the triacylglycerol, triglycerides, neutral fat about 88%. So the major lipid which is present in the chylomicron. You'll get questions which is the major lipids found in the chylomicron. So that is triglycerides, neutral fat. And the major functions of chylomicron is deliver the dietary lipids, deliver the dietary lipids. So this is the all about the chylomicron. So coming to the metabolism of chylomicron. So as I already told you here, source is a small intestinal cells. So dietary triglycerides, through dietary triglycerides in small intestine, through lymphatics, we are getting nascent chylomicron. After the digestion and absorptions, after that we are getting nascent chylomicron. In nascent chylomicrons, so this is the earlier stage of chylomicron, nascent chylomicron. So you can see here B48 is there, triglyceride and cholesterol is there, apoprotein A is there. In nascent chylomicron, a protein C and a protein E is going to aided by the HDL. So HDL is a donor, acts as a donor for the nascent chylomicron. So from HDL, nascent chylomicron is going to get apoprotein C and apoprotein E. Then finally, that is going to convert into the chylomicron. So that is the mature chylomicron. So mature chylomicron have apoprotein B48, apoprotein E, apoprotein A, apoprotein C. So this is the mature chylomicron. And with the help of lipoprotein lipase enzyme, as you all know that lipase comes under the hydrolysis group of enzyme. Okay, so they need water molecules. Okay, here lipoprotein lipase is going to break down the chylomicrons, and then finally we are getting derived lipids. So that is the fatty acid is going to release, and the glycerol is going to release out, and then a protein NC is going to donate it to the HDL, and then finally the remaining product. So that is the chylomicron remnant. and then fat acid is going to enters into the extrahepatic tissue. That fatty acid, extrahepatic tissue. And finally, remaining the molecules, that is the nothing but the chylomicron remnant. So that chylomicron remnant have a small amount of triglyceride and cholesterol, and then there is a protein B48, a protein E, and then that chylomicron remnant is going to enters into the liver, and there that gets break down into the simplest one, and then finally cholesterol and fat acid is going to release there, and there is a LDL receptor, okay, and then again the liver, from liver HDL is going to release, okay, and like that the metabolism is going to occur. So this is the exogenous pathway of lipoprotein metabolism, or we can also call it as a chylomicron metabolism. So like that, chylomicron is going to synthesize and going to further break down. Okay, so this is called exogenous pathway of lipoprotein metabolism. So this is also the simplest one. Coming to the another one. So another one is VLDL metabolism. So VLDL metabolism is called as a endogenous lipoprotein metabolism pathway. Endogenous. Previous one is chylomicron is exogenous, and VLDL is endogenous. So you must know endogenous and exogenous at least. So endogenous pathway, you can see here the VLDL, the source is liver. Why it is so called? Because liver is going to synthesize. Previously, we are getting from the exogenous source, dietary source. That's what is the exogenous pathway. Now the liver is going to synthesize. That's what is called as the endogenous pathway. And the diameter is 30 to 90 nanometer. So previous one diameter is see 90 to 1000 nanometer, whereas VLDL 30 to 90 nanometer. Density is 0.95 to 1.006. The protein content, the previous one is 1 to 2%. But here, the protein is gradually going to increase 7 to 10%. Whereas lipid is almost quite going to quite decrease. That is previous 98 to 99. Now it's a 90 to 93%. So lipid content is 90 to 93%. You must know the content, protein content, lipid content. So you can make a chart of these different lipoproteins for your remember purpose. Okay. And the major lipids, triglycerides. Previously, the triglyceride is almost about 88%. So quite decreased, the content of triglycerides is decreased here. So that is only about 56%. Okay. So neutral fat triglycerides is about 56%. And the functions of VLDL deliver endogenous lipids from liver to peripheral tissue. Okay. Okay. So I'm going to talk in simple language, okay? Simple English. As you are bachelor level students, you must know, okay? That's what, and the important topic is, and I'll give you the recording. You can revise that one. So major lipid is triglycerides. Previously, in chylomicron also the major lipid is triglycerides, but that is about 88%. Okay. Now that gradually decrease, that is about 56% major lipids. And the major functions of that VLDL is delivered the endogenous lipids, not exogenous, inside the body. There is endogenous lipids. Okay, so endogenous lipid from liver to peripheral tissue. They are going to transport the endogenous lipid from liver to the peripheral tissue. So that is the major functions of VLDL. Just see the metabolism, very important topic. This one you'll get a long questions in your Lok Sabha Public Service Commission exam. Okay, just see here. As I already told you, this is the pathway of endogenous. Previous one is exogenous. Why? Because we're getting that from dietary source through intestine. Now the liver is going to synthesize. That's what is called as an endogenous pathway. So from liver, nascent VLDL is going to synthesize. And the nascent VLDL have apoprotein B100, apoprotein E, apoprotein C. Whereas you are getting the lipid is triglycerides and cholesterol is there. It's a major lipid is triglycerides and then cholesterol. So this is also called, you can call as a immature VLDL. So finally, that nascent VLDL is going to convert into the mature VLDL. And HDL is going to donate a protein C and a protein E to the nascent VLDL. And then finally, it is going to convert into the VLDL. And that contain a protein B100, a protein E, a protein C. So this is the mature on how the VLDL is going to synthesize. You can see here. And now it VLDL gets breakdown by the enzyme lipoprotein lipase. Just compare it. Endogenous and exogenous pathway. There is a quite difference. Not that much. There is a quite difference. At least you know endogenous and exogenous. These two pathway. Okay. So lipoprotein lipase is going to break down the VLDL, and then finally there is you can get here fatty acid is going to release, and that fatty acid is going to enters into the extrahepatic tissue outside the liver. That is extrahepatic tissues. And then glycerol is going to release, and then VLDL is going to further break down to the simplest one, that is called ideal. So intermediate density lipoprotein, you can call it as a ideal. And another name of ideal is remnant of VLDL. Once VLDL break down, so the remnant one is called as a ideal. So in between the LDL and VLDL, there is the product. So that product is called as a VLDL remnant. Nowadays, you can call it as a ideal. So that ideal which contains apoprotein B100 and then larger amount of triglyceride and cholesterol is there, and then a protein E. And then a protein C is going to donate it to the HDL by the VLDL. And again, ideal is going to convert into the LDL. Just see here in difference between the LDL and ideal. In ideal, there is your triglycerides. But in LDL, there is a cholesterol. There is no triglyceride at all. In ideal, there is a protein E, but in LDL, there is no protein E. So only a protein B100 is there. And then cholesterol is there. Okay. And that LDL going to further break down. And then that somewhat molecules is going to enter into the extrahepatic tissue. And there is a LDL receptor is there. And through the receptor, the LDL molecules is going to enter into the liver and gets breakdown. and then cholesterol and fat acid going to release. And again, there is a synthesis of nascent VLDL, and again nascent VLDL is going to convert into the VLDL. So like that, the metabolism is going to proceed. So somewhat I'm going to tell about the ideal. So ideal is nothing but the intermediate density protein, and is already told you that it is also called as a VLDL remnant, and this is the breakdown product of VLDL. They are involved in cholesterol transport, and that can be taken up by the liver and gets converted into the LDL, and it is composed of triglycerides and cholesterol. And this ideal play a role in the development of atherosclerosis, which leads to the heart disease. Okay, so ideal is going to play a role in the development. So clinical aspect is there for the atherosclerosis, and that leads to the heart disease. So there is a erythromatic plug is going to form. As I already told you in much detail during cardiac function test, you can remember that mechanism and all these things, and I already showed you the PPT. You can go through that. So ideal is the responsible for that. So if I'll talk about the functions of ideal, so ideal is going to form from VLDL, and you'll get in muscles and adipose tissue, and it is involved in the transport of cholesterol, both from the liver to the peripheral tissue, and peripheral tissue again back to the liver. And the clinical aspect is related to the atherosclerosis. So this is the overview of metabolism of endogenous pathway. So if there is an elevated level of ideal, that means the increased risk of development of atherosclerosis. So that is the condition where plaque is going to form in the artery, and that leads to the heart disease. And that another significance of ideal that can contribute to the formation of plaque by facilitating the accumulation of cholesterol in the arterial wall. So what happens if there is a clot? You can't get the proper movement of blood flow, and then the problem of heart will arise. And another property of ideal, that ideal molecules can be more easily oxidized. Just see here, right? The ideal molecules, particles can more easily going to oxidize. So coming to the LDL metabolism. So if I'll talk about the LDL, the source is VLDL. As in previous metabolism, endogenous pathway, We already discussed about the metabolism, how LDL is going to synthesize. So this pathway can not only the VLDL but also IDL and LDL as well and HDL. Okay, because here you can see here LDL is going to synthesize and is going to break down. Same this, so there is no need of another pathway. Just you can go to the endogenous and exogenous pathway. These two pathways are enough for the lipoprotein metabolism. The source is LDL. So VLDL, very low density lipoprotein. The source of LDL is VLDL. And diameter is about the range 20 to 25 nanometer. Whereas density of LDL is 1.019 to 1.063. And the protein content gradually going to increase if you compare the previous one. Okay, so it is about 21%, whereas lipids content gradually decrease only about 79%. And then the major lipid in previous one there were triglycerides, but here in LDL we're getting cholesterol esters, that is about 48%. You'll get questions, which lipid is present there in ILDL? So there is a cholesterol, not a triglyceride. Cholesterol is the major lipids present in the LDL. And then functions of LDL, deliver cholesterol to tissue, peripheral tissue and extrahepatic tissue. Hepatic and extrahepatic tissue. So they are going to deliver cholesterol to the tissue or peripheral tissue, again called as peripheral tissue. So LDL that referred to as a bad cholesterol. Why? Because this is the type of lipoprotein that carries cholesterol through the bloodstream. So according to that, due to that, if the more LDL, so more functions will proceed, so more cholesterol will transport through the bloodstream. So there is increased cholesterol inside the blood, and that affects the heart. So that's what is called as a bad cholesterol. And another name is lethally desirable lipoprotein. So LDL have three names: low density lipoprotein, lethally desirable lipoprotein, and bad cholesterol. Why it is so called a bad cholesterol? Because it carries the cholesterol or fat through the bloodstream. That's what is called as a bad cholesterol. And high level of LDL cholesterol contributes to the build of plaque in the artery. So increasing the risk of heart disease and stroke. That is nothing but the myocardial infarction, heart attack. In common, we can call it as a heart attack. Here, as I already told you, high level of LDL cholesterol leads to the formation of plaque, erythematous plaque in artery, and the process called as a atherosclerosis. And that plaque narrowing the artery and can restrict blood flow, that potentially leading to heart attack and stroke. So that's what it is, a bad cholesterol and lethally desirable lipoprotein. So how it works, how LDL works, just see here how the plaque is there, the macrophages, and then again that cholesterol, how it is going to oxidize the LDL or the LDL, how it is going to oxidation, and then there is a plaque is formation in their arteries, and there is a that affects the functioning of heart. Okay, so how it works, how the mechanism is there. LDL, this LDL particles transport cholesterol from liver to cells throughout the body. When there is a too much LDL cholesterol, bad cholesterol into the bloodstream, it can going to deposit it in the artery wall, and contributes the formation of plaque, and they are going to narrowing the artery. So what is the relationship or clinical aspect of LDL to heart health? So maintaining healthy LDL cholesterol level is crucial for the heart health. That's what we have tried to decrease the LDL cholesterol level. If there is a low LDL cholesterol, so there is a less chance of heart disease. If LDL content is more, there is a high chance. So lower level of LDL are generally better as they reduce the risk of plaque building and associated cardiovascular problem. So our intention is to decrease. Our aim should be how to decrease LDL cholesterol. Okay. So there are some factors which affect dietary factors and physical activity, which will, if you are physically active, if you are doing a regular exercise, if you are consuming much more fiber rich diet, so that will decrease your LDL cholesterol. So healthy diet and regular physical activity helps to lower your LDL, bad cholesterol. So as I already told you why it is called as a bad cholesterol. Just see here, as I already told you the mechanism. In addition to a highly specific and regulated receptor mediated pathway of LDL uptake, macrophages possesses high level of scavenger receptor class A, SRA molecules, which is not down regulated unlike the LDL receptor. So cholesterol esters accumulate in macrophages. So macrophages transform into form cells, which further participate in the formation of atheromatous plaque. So that is the mechanism, as I already told you. Coming to the HDL metabolism. So HDL is so-called high density lipoprotein. You can also call highly desirable lipoprotein. You can also call good cholesterol. And source of HDL is liver and intestine. The source of HDL is liver and intestine. Just see the previous this mechanism, this pathway. The source of HDL is, this is the liver, and intestine is the source. So main is the liver one. And HDL have two forms, HDL2 and HDL3. So HDL2, the density range is 1.063 to 1.125, whereas HDL3 have 1.125 to 1.210. And the major lipid you can see here, phospholipids. that is 20 to 30% is there, phospholipid. You'll get MCQs questions. What are the lipids present there in the HDL? So phospholipid and cholesterol esters. In LDL, there is only cholesterol is there. But in HDL, there is a phospholipid and cholesterol. And cholesterol is a lesser amount. That is only about 15 to 25%. And the functions of HDL is transport cholesterol from peripheral tissue to liver, so-called good cholesterol. And the reservoir of a protein C and a protein E is already we discussed in the metabolic pathway. They are going to donate a protein C and a protein E. So the reservoir, the collection of these proteins have. That's what we can call it as a reservoir of protein C and E to the HDL. So higher HDL means there is a lower risk of heart attack and stroke. Lower HDL means higher the risk of heart disease and stroke. And the function of HDL, I already told you, HDL acts like a garbage truck for cholesterol in simplified language. So picking it off from cells and artery and then transporting it to the liver for disposal. Same like a waste garbage truck. That means whatever the cholesterol is there, whatever the inside the blood in peripheral tissue, they are going to transport into the liver for the disposal. So HDL acts like a garbage truck for cholesterol, picking it off from cells and artery and transporting it to the liver for disposal. So that's what. So they are going to decrease the cholesterol level. So they are going to maintain the cholesterol level inside the blood, inside the body. That's what we can call it as a good cholesterol. So it helps prevent the buildup of cholesterol in the arteries, so which can lead to the heart disease. So there is a lesser chance. If the more HDL, the lesser chance of heart disease. And the normal range, if I'll talk about the normal range of HDL, as I already told you in lipid profile, so it should be more than 40 mg per deciliter in male, whereas in female, it should be more than 50 mg per deciliter. And the factors like dietary factors, physical activity, and quitting smoking will increase your good cholesterol. And we can also called as a HDL as a security guard of heart. And another role of HDL, some research says that HDL also play a role in other processes like immunity and possibly even cancer survival. Through more research is needed in this area. Some research says that they have role in immunity and cancer as well. So there is a
Pure
much
cancer
more
solo,
research need
sir.
for further confirmation of another functions.
HDL play roles in treatment of cancer, sir.
Coming to the lipoprotein A.
Hello.
So lipoprotein A, that is the lipoprotein subclass. And nowadays, it have some important aspect in our health. So lipoprotein A, we can also call it as LPA, is a type of lipoprotein. That is the particle which carries cholesterol in the blood. It is a type of lipoprotein particle which carries cholesterol in the blood. Same like LDL. That's what, if you compare the structure of lipoprotein A and LDL, you will get nearly identical. So it is similar to LDL cholesterol. That's what the elevated level of lipoprotein A, which are associated with an increased risk of heart disease and stroke. Why? Because due to its potential to contribute to plaque buildup and blood clot formation and inflammation in the artery. That's what we are going to measure the lipoprotein A. If lipoprotein A is more, so there is a high risk of chance of heart disease. If it is less, there is a less risk for the heart disease. So it is directly linked with the heart disease and a stroke and other cardiovascular disorder. And here, those having family history of heart disease, in that case, we'll get lipoprotein A is higher. And if I'll talk about the ethnicity, African South Asian population have a lipoprotein A is quite higher. And some condition, clinical condition like uncontrolled diabetes, chronic kidney diseases, postmenopausal women have a increased lipoprotein A. So that's what in diabetes conditions and chronic kidney disease conditions, so there is a chances of heart attack as well. That's what we have to do the test, how much lipoprotein A is there inside the blood. So some hospital and some clinical doctors, they always used to refer the lipoprotein A test. So lipoprotein A is a genetic risk factor for heart disease that is often overlooked, understanding and impact cardiovascular health. In crucial for making informed decision about the management of heart disease and risk. That's what we have to regularly measure lipoprotein A for the clinical aspect and for the heart health. So coming to the applied aspect of lipoprotein. So we can call it as a disorder, we can call it as a dyslipidemia. If there is an increased lipoprotein, that is called hyperlipidemia. And these are the different types of classifications of hyperlipidemia. We can call it as a Friedrichson's classifications. So type 1, type 2A, type 2B, type 3, type 4, type 5 hyperlipidemia. So type 1, what is the lipoprotein disorder there? Hyperchylomicronemia. So increased chylomicron in the blood. In type 2A, Here, familiar hypercholesteremia. Type 2B, there is a hypercholesteremia. Type 3, dysbeta-lipoproteinemia. Type 4, familiar endogenous hypertriglyceridemia. Whereas type 5, hypertriglyceridemia. So this is the disorder or applied aspect and different types of hyperlipidemia. So this just quite much detail. You can see here there is a in type 1 there is an increased chylomicron, whereas in type 2A there is an increased LDL. Type 2B there is LDL and VLDL increased. In type 3 increased IDL. Type 4 there is increased VLDL. Type 5 VLDL chylomicron is going to increase. And you must know the defect, respective disorder and defect. What is the defect there? At least you should know. Okay. So lipoprotein lipase deficiency is there. Due to that deficiency, so type 1 is there. LDL receptor deficiency is there in type 2A, whereas type 2B, overproduction of protein B. Whereas type 3, abnormal protein is there. In type 4, overproduction of triglycerides. And type 5, secondary to the other causes like diabetes mellitus, alcoholism, and obesity. So at least you know the applied aspect and disorder and respective defect, remaining for your sake of knowledge. So if there is a decreased lipoprotein in blood, that is hypolipoproteinemia. So beta lipoproteinemia, that is Bason's and Carvajan's syndrome. If you need, you can go much detail, otherwise no need of that. And metabolic defect is apoprotein B. So this is the, here is the chart, summary chart. You can go through this one. This is the respective disorder of beta lipoproteinemia, and the cause is defective microsomal triacylglycerol transfer protein defect is there. Familiar hypo beta lipoproteinemia, so reduced aprotein B synthesis is there. Whereas Tanger's disease, that is also called as hypo-alpha lipoproteinemia, and the defective ABC1 protein is there. So this is all about the applied aspect. And atherosclerosis, I already taught you in a cardiac function test. Though the name itself indicates athero means soft lipids, sclerosis means hardening. So it is a complex disease characterized by thickening or hardening of artery due to accumulation of lipids, particularly cholesterol, collagen, and fibrous tissue, proteoglycans, calcium deposit, and into the inner arterial wall. And finally, due to that, the vessels is going to narrowing. And this is the plug, erythematous plug. So a progression disorder that narrow and ultimately blocks the artery. Just see here how it is going to block. So disease in which plaque forms in the wall, the major artery constricting the lumen of the vessel. So lumen is going to constrict here. So how the blood is flow? So blood flow is going to alter here. And then, so their problem of heart is going to arise. So just see the mechanism, how atherosclerosis is going to develop. So injury to the intracellular cells of artery, LDL is going to oxidize. So entry of LDL into the intimal layer of artery. Just see here, this is the different layer of artery, tunica media. So this is the tunica media, and this is the elastic lamina. So these are the different layers. This is the adventitia. Okay, so this one is lumen. So what happened? So entry of LDL into the intima layer of artery, then uptake of oxidized LDL by the macrophages. So macrophage is going to uptake that oxidized LDL. So this oxidized LDL is going to uptake by the macrophages. So what happened? There is a formation of foam cells. And then development of fatty streaks is there. Due to that, development of atheromatous plug is there. So this is the atheromatous plug. Just see here how the fatty sticky is there in the vessels, inside the vessels. And the molecules are going to attach on, and the formation is going to, clot formation will take place. And then plug protrudes into the arterial lumen. Then impedes blood flow and makes blood flow turbulent. So increased risk of blood clot formation is there. So plug may dislodge and exposes collagen, aggregation of platelets. So platelets going to aggregate. And then finally blood clot formation is there. So this is the blood clot formation. So platelet is going to aggregate there. So it is going to seal out. So finally blood clot formation is there. And then ischemic death of affected tissue. So coming to the risk factors, who are the major risk factors? So these are the major risk: age, sex, genetic factor, familial and racial factors, and those having hyperlipidemia, hypertension, uncontrolled diabetes mellitus, those are smokers, hyperchromatocystinemia. So these are the major risk factors. Whereas minor risk factors, obesity, hormones like estrogen deficiency, and those people who are prolonged use of oral contraceptives, they are also chance. Okay. And then physical inactivity and a stressful life. Stress is the central cause. These days we can call it as a central factor. Nowadays, stress is the central, and another is obesity is the central factor. Not only the heart disease, but also other diseases. Okay. And chronic alcoholism. So this is the minor risk factor. So how you will prevent the atherosclerosis? So how you will prevent from heart disease? So there are two ways to maintain your good cholesterol and bad cholesterol level. So our aim should be how to increase good cholesterol. If we are able to increase good cholesterol, definitely your bad cholesterol will drop out. And the cholesterol lipid profile will be maintained. Okay. So there are two ways. One is physical activity and dietary modification. These two are first line of treatment. In dietary modifications, you have to prevent saturated fat in your diet. You have to prefer high amount of unsaturated fat. And the major source of unsaturated fat is flaxseed. The flaxseed contains, we can also call it as in simple language, allus. Okay, that have more than 3 times of omega-3 fatty acid if you compare with the ochre and then fish cod oil. Okay, 3 times high. Too much good for your health. The flaxseed, that allus, in common language can call it as a allus. Okay, so they have much more amount of unsaturated fatty acid, omega-3 fatty acids. So we have to use regularly. And high fiber rich diet we have to prefer. We have to prevent refined sugar. Okay. So intake of vegetable oils and fish oil. Okay. So rather than those who are vegetarian, we have to prefer flaxseed. They contain more than, they contain much more omega-3 fatty acid than fish oil. Okay. And that is also can called as a polyunsaturated fatty acid. They are good to our health. We can also, in another language, can also called as essential fatty acids. And we have to decrease carbohydrate diet and fat diet. We have to decrease, and we have to increase intake of green vegetables and fruits, and avoid sucrose, that is refined sugar in cigarettes, and regular exercise. So regular exercise will increase your HDL, good cholesterol. So jogging is the best way. Jogging and cycling is the best way to increase your good cholesterol. And unsaturated fat acid, trans fat, we have to prevent. If though we are unable to maintain the lipid profile, then clinician will prescribe your medicines. Then afterwards you can go for the medications. But before starting the medications, I strongly recommended physical activity and dietary modifications. If you are able to decrease only 50% of carbohydrate in regular diet, definitely within a few months, your health will be maintained. So extra carbohydrate is too much dangerous. Why? Because through extra carbohydrate, endogenous fat is going to synthesize. So that endogenous fat is too much dangerous. And antioxidant, vitamin C, vitamin A, vitamin E is the major antioxidant vitamin we have to prefer in our regular diet. Okay. And regular physical activity, physical activeness will maintain your good health. So try to maintain all these things. Definitely, once you will think, definitely you can maintain. So our aim should be increase the good cholesterol level. So there are two ways, as I already told you, to increase HDL. One is dietary modifications. Another is physical activity. In dietary, so increase fiber in diet. Fiber rich diet should take quite more, and lean protein like a fish is the good for health. And nowadays you all aware of soya protein. So soya protein, that is also going to increase HDL. And exercise and cycling will increase your good cholesterol, HDL, and they will going to decrease your LDL. And lifestyle modifications, like those who are a smoker, they have to quit smoking. Those who are consuming, who are taking more alcohol, they have to limit the alcohol consumption. And those who are overweight, according to height and body weight, so they have to maintain healthy weight. And another major thing is that we have to manage our stress. As I already told you, stress is the central factor. Okay. So if you are able to manage the stress, definitely your health will maintain. Okay. So this is the tips for the day, how to maintain good health. So nowadays, stress and is the central factors. So those will take a regular stress at least 15 to a month. Definitely, there is a high risk of development of cardiac disease and uncontrolled diabetes mellitus. There is a high chance of development of diabetes mellitus. Okay, so how to maintain your good health, how to maintain your health, your heart in a good conditions, that depends on you. And I already told you much more way to maintain non and we are much more way to prevent non-communicable diseases in insulin resistance topic. And the back villain is insulin resistance of almost all the non-communicable diseases. And there also I told you there are only two way, and that is also called as a first line of treatment. That is, one is dietary modifications, and another is physical activity. That is the way we have to maintain our good health. We have to keep our body healthy, and we have to prevent from non-communicable diseases. So that is the two way. If you think, definitely we can maintain our good health